Thank you for joining us today for the meeting of the New York City Health and Hospital Information Technology Committee. Today's meeting is officially called to order. For the record, please note that Dr. Allen is representing Dr. Katz in voting capacity. Next on the agenda, I would like a motion to approve the minutes of the Information Technology Committee meeting held on September 12, 2022. Any seconds?
Second.
Thank you. Let me get, can I get a voice vote? Is that okay? All in favor?
Aye.
Anyone opposed? Anyone abstain? Um, the resolution passes. Thank you. Next, we will have the CIO report. Thank you.
Thank you, Chairman Pinamora. I'd like to introduce my team. First, I'll start with myself. I'm Kim Mendez. I'm the CIO for New York City Health and Hospital. Directly across from me is Ashoma Badori. She's our Chief Information Security Officer. Next to her is Apoorva Karia. She's our AVP for EITS Finance and Business Administration. Over here on this end is Jeff Lutz. He's our Chief Technology Officer. And immediately to my right is Dr. Michael Boughton, who is our Chief Medical Information Officer, as well as over clinical applications. I'll start today. Thank you. So the agenda is up for viewing. We can see that I'm going to focus on three key areas that are aligned with our EITS goals for 2022. We will talk about the data center migration and that initiative, our current update. We'll have an update from our CISO for around cybersecurity. And then we'll talk a little bit in detail on some of the most recent clinical informatics and applications that we have actually implemented across our system. We can go to the next slide, please. And here, just as a reminder, all of our goals for information technology are aligned with the strategic pillars of New York City Health and Hospital. I can bring your eye down to the second large bullet, which is the infrastructure enhancement. There we'll be talking about the data center and the great strides we have made there. Further down, the fourth bullet is the H2O, which is our EPIC electronic health record and the effective use. And we'll be discussing the MyChart, how we have actually launched several new modules around EPIC. And then bringing further down is our ongoing continuous quality improvement. And today we'll focus on security and risk assessment from a cybersecurity perspective. And go to the next slide, please. Here we'll talk about our data center migration. Just to remind everybody, this is a 2-year project that will be completed in May of 2023. I'm very happy to announce that this is a phased project that actually overlaps itself, but we have completed the first migration to our new data center at QTS in Piscataway, New Jersey. I'm going to turn it over to Jeff in just a moment, but we are completely out of SunGard at this moment, which was our goal. So we were on target and on budget for that. And we are now moving and have been preparing for the second wave to the new data center, which is Cyrus 1, which we anticipate to be completed by the end of May 2023. I just want to pause and I actually had the opportunity to go to Piscataway and see the new data center there, and the real takeaways that I had when I left that day-long tour was around resiliency and security and redundancy of our system. So it was a very, very good tour. Jeff, let me turn it over to you for some of the more detailed components of that from this slide.
Yeah, no, thank you, Kim. And as you had mentioned, so we were able to meet our goal of being out of SunGard prior to the contract ending, which officially ended yesterday. I do want to take a brief moment, and we've been at SunGard for 17 years. While we're excited to be with our new partner, they were great partners for us, especially as we look back with being on our 10-year anniversary of Sandy, where they were very valuable partners, not only from within the data center, but adding resiliency to us. So we had some great support, but we're excited to be in with our new partners and at QTS. And it was great to have Kim and Shoma come out and show the area. We are completing the last of what's left there. Basically now is just to take out equipment and things like that, but there's no services. Everything was all shut off there within the middle of October. So, and just thank you to the team for making that so smooth.
May I have a question? Um, SunGuard was an outsourced arrangement.
Yes.
Was there any equipment from Health and Hospital? Are there facilities? How are they being decommissioned? And then going, since you're the chief safety, how is the data being, scrapped or shredded digitally so that everything will be moving forward in the best possible way?
Yeah, it's a very good question. So the SunGuard, much like these two new data centers, same thing is it's a hosted facility. So all of the equipment inside of there was Health and Hospitals equipment. They provided us locked storage or locked area, a cage essentially, where all of this equipment was stored, and so we were the only ones that had access into these areas. The equipment that was not moved to the new location or that is not being repurposed, there is some equipment that we're going to use to repurpose across the enterprise, but any of that was not, that's left, follows our relinquishment process that we have, where basically we have vendors that come in, they help us to, not only decommission, but they'll also ensure that any of the data that's on those disk drives that remain are completely wiped, and we get validation to that effect. And same with any of the other equipment that gets relinquished. We get appropriate certifications and documentation to say that this equipment is no longer in use there.
And there is no resale value to any of that equipment.
Very good question. We actually for example, Dell, where there is some areas that we do have resale value, we've actually been working with them, and we do get trade-in value for them with that. So they'll take it, and then they work to relinquish it, but then they give us credits that we apply to future purchases.
And before we resell it to them or give it to them, that's where the whole process of the data.
Oh, very much so. Yes. We still generally we won't give them the hard drives, or they'll destroy everything at that point as well.
In a lot of situations, you hear a lot about military grade kind of deletion of data. Do we use that type of grade, or because we are a hospital and have so many requirements, we have other types of certifications in terms of ensuring that all the data has been erased and there is no way to recover any of that?
So, and from a military perspective, that would be basically at the federal level, where in terms of encryption, you would have a FIPS regulation. But for the city, we normally follow state guidelines where we have a clear mechanism for wiping and removing all of the data from the systems that we no longer have. Just to clarify a little bit on the servers that we do have. That are at the data centers, as part of the HIPAA security rule, we have to have encryption on all of those systems to ensure that the data that's residing at rest is encrypted, and data that's being transmitted within the data centers are also being encrypted in transit. So there's a clear process we follow as part of our policies to make sure that the data is wiped, as Jeff mentioned, and we have the encryption guideline as well as part of the HIPAA security rule.
Thank you. I just want to ask all the members if they have any questions. Sorry that. Okay. Thank you.
Yeah, no problem. And just to finish up, now we're on to the next, to Norwalk. So design and preparations are already in place for that. And if you want to go to the next slide.
I just have another question. The next kind of big milestone will be to migrate all our facilities from Jacobi. Is that going
Correct.
to be?
Yes.
And I think we discussed that in the past, but maybe you can refresh our memory. What are we going to do with the space where these were held? How we're going to manage? I know that there was some discussion, but I now don't remember all the details.
No, so actually, the data center in Jacoby currently serves two purposes today. It is not only our data center, but it actually also it serves as what we call an MDF, so a main data frame, as they call it, but it's a central hub where all of the communication comes into that supports the network and for access to Epic and the internet, and email throughout the campus there at Jacoby. So it will remain in that capacity for us in that facility, and it allows us to. There's another one that we're working with Chris Mastromano to build out, so that we typically like to have two, so that we have redundancy that's there. So that space will continue to be maintained in that capacity. At the very least, there's some other areas that we've been exploring for it, but at this point, at the very least, that's what it's going to stay there, and it's still a crucial part of that campus for us.
Thank you.
And again, this slide here just shows the timeline, which, as Kim had already mentioned, we've already stayed aligned to. So, next slide.
Okay. So we'll transition now to our next topic, which aligns with quality and outcomes. And this is our cybersecurity. This is a high-level overview. Just to say that October was Cyber Awareness Month, and we felt that this was a good opportunity to kind of highlight some of the high-level key areas that our team has been working on. Shoma?
Thank you. Hello, everybody. So I just wanted to give an overview of our cybersecurity strategy. So cybersecurity, as you all know, has become an important component in ensuring a stable environment to provide patient care services throughout all of H&H's facilities. And to ensure our security posture is managed appropriately, we utilize the National Institute for Standards and Technology Cybersecurity Framework, or what's known as the NIST-CSF. This framework aligns with the HIPAA security rule, as I mentioned earlier, which allows us to ensure electronic personal health information, or EPHI, is being stored and transmitted securely. It allows for continuous monitoring of the security program and provides regulatory compliance, to name a few of the items. The key components of NIST CSF is to identify, protect, detect, respond, and recover from a cyber event, as noted in the graph there. With that in mind, there are a number of key initiatives that have come from the EITS Enterprise Risk Assessment. To start off with, over the last couple of years, and the first bullet at the bottom is basically with our legacy systems, which include our desktop servers and databases. So this is basically a cyclical process that continues to be a focus to reduce our risk level by upgrading with appropriate funding to the latest operating systems with proper testing of systems that support our clinical applications. And finally, in the last year, we have acquired a biomedical device risk management technology, Assimile, that allows us to assess the risk level of all biomed equipment enterprise-wide. So this has allowed us to remediate high-risk devices as needed for the entire system. The areas of multi-factor authentication, as noted here in the graph, in the bullet point, and personal email restriction all help in reducing email compromise, mainly through phishing attempts. And our MFA has been implemented for all of our public-facing sites, including Webmail and PeopleSoft, as examples. Also, all personal email sites have been restricted from being accessed within the H&H network. Finally, interagency collaboration with federal, state, and local agencies allow the H&H Security Department to stay on top of the latest trends and attack vectors to properly protect our public hospital system. And in addition, continual education and learning of our workforce, such as Cybersecurity Awareness Month that Kim has mentioned, are important components of our program, which I will touch upon in the last slide. Next slide, please. So here I just wanted to provide some metrics to kind of highlight the NIST CSF and what we're doing. So these are some metrics being highlighted to give an overview of our cybersecurity program here at Health and Hospitals, and the fact that attackers are continually trying to compromise patient care services by attempting to enter our network. So here the threat landscape diagram shows you what H&H gets impacted with on a daily, weekly, and monthly basis. This includes continuous blocking of viruses, malicious websites, and phishing emails, and prevention of EPHI from leaving the H&H network. It shows the automated technologies that we have implemented to prevent as many threats as possible from entering our perimeter, including malicious campaigns such as ransomware. Now, on the right side graphic, you can see is the monthly phishing exercise results highlight the importance of the continual education of our large workforce. The graph shows on a monthly basis how the entire workforce responds to a simulated phishing email. It shows that those who clicked in pink and those that have reported the phishing email in green. In general, H&H fish prone rate is about 6.8% for a 45,000 plus workforce, whereas the industry average in a healthcare system that is over 1,000 workforce members is around 6%. In essence, automation and education go hand in hand in protecting H&H from a cyber incident. Next slide. And the last slide. So I just wanted to close out with this last slide to highlight Cybersecurity Awareness Month, or CSAM Month, that we just wrapped up in October. The theme this year, as you can see, was to see yourself in cyber, which makes sense with everything going on right now in cybersecurity. Our CSAM sessions were held once a week for all workforce members, from phishing recognition to the importance of multi-factor authentication and how it was implemented to also need the need for strong passwords from our CISA speaker that happened last week. And finally, how the EITS onboarding process allows all new technologies to be onboarded securely without compromising our security posture. So this basically closes out my presentation. I hope I provided some clarity on the H&H security program here. Any questions are welcome.
And I would just say that, our education is ongoing. You can see we do these simulated internal phishing exercises continually. And we also continually develop, strategies for our staff to report them. If you look at your current Outlook in the upper right-hand corner, it has a little PHIS. If you click on an email and you feel that that has a potential phish email, all you have to do is just click the word fish, and it sends it right over to Shoma's team. Wow. So there are, we continually looking at how to streamline the reporting and to help individuals identify and see themselves, as a potential.
So what would be a clue that what I'm reading is a fish, falls in the fish category?
I'll let Shoma. There's many things, but
So they've gotten very complex, to be honest. It could be something like an individual that you're familiar with has emailed you, but the email is actually coming from another email address, but the name looks familiar, like a friend or a colleague. And then maybe they send you a link and say, hey, can you Venmo over something, in terms of like, in
Like my
in terms
social
of some
security
kind of,
number.
right. Or you basically could, if you click on the link, then that's how that personal information can be sent to the wrong people. So you have to be very careful in terms of the source of the email, but to try to put your mind at ease a little bit. I work closely with Jeff in terms of our infrastructure areas, and one item we have implemented is basically Ironport, which blocks, as we saw in the threat landscape document, millions of phishing emails. So those have reduced in number, but then we also test our workforce to make sure that they're kind of active and they're making sure that if they see something, they report it, as Kim mentioned.
So that actually prompted my question, looking at that graphic. The green is what's reported and the red is what's been clicked, and I didn't understand.
So
is it duplicative or really separate data points?
it could be duplicative. That's a great point. So basically, the one in pink are those that basically clicked on the email, which is attributing to our 6.8%. Okay, and the one that is in green are obviously maybe they're clicking the link, but they're also reporting it.
Got it.
If they're not reporting it, then that's basically they're not looking at the email or
Just deleting it straight up.
deleting it straight up.
and this is our exercise, just so you know. This is our
exercise.
This is our exercise that we test.
This is like your quality control.
Yeah.
Yeah.
So
exactly.
when you open the email.
It's
then
not
there's
really a
gonna be
phishing email.
Prompt to, to hit a site.
Right.
So is it the opening of the email or is it the clicking to
Great
actually
question.
go to the phishing site?
So basically, when you go through a cyber event, there's many steps. It's what we refer to as the attack layers. So the first thing is you look at the email, then you click on the link. When you click on the link, and if our systems don't block that particular link, and then you're providing that information, then that's where your information could be compromised. But that's what we try to prevent through our
But on
automation
your
mechanisms.
test, you're sending the email
Yes.
and you're providing a link.
Correct.
And so is the pink
When they
people
click.
who actually click the link?
Yes.
Ah.
Yes.
Interesting.
Which is
Okay.
the 6.8%.
Gotcha.
And then just to add, if they do click on the link, we automatically get that information for the user, and we provide additional training to try to reduce the level. So it's an ongoing effort.
Can you give us a footnote on how to do this when we're on our own devices? Just
Sure.
shut it down immediately?
Oh, in terms of the,
Any concern about an email or something coming through?
yeah, I mean, if you're concerned that something has happened, we always ask that you report it to our help desk, and my team actually has a very stringent process on what we follow, and we make sure that that gets investigated. Most times, like I said, our systems do block it, but if you feel like something has happened, that's where Kim mentioned, basically, if you click the fish button, then that will automatically start that procce.
I think to Barbara's point, maybe I
Yeah,
understood,
from
with
but
home,
my
I
own
think.
Oh, from
device.
home, oh, I'm sorry, yeah, sure.
I pulled the plug.
that's
I didn't
the
get that,
point.
sorry.
Don't click
I
on
mean-
anybody you don't know.
Exactly.
Call your friend first.
But I guess the point is, if you did,
Yes.
then I think what Lo's asking is, okay, well now what?
You know, the
feel
best,
you maybe.
yeah, probably the
it-
best thing to do when a
Is it
person,
instantaneous when they get that link, or is it
yeah.
the process where they still have to pull stuff out of your?
No, once you send the information, unfortunately, it's
Right.
pretty instantaneous, especially if you're sending money, which happens a
Right,
lot.
sure, sure.
You know, so the best thing to do is, if you're questioning it, is to call the person. If you call the person and be like, what are you talking about? You know, I didn't ask you for money or whatever, then that's probably the best
One
way.
clue I got, because someone is doing an Amazon thing, and when I called,
Yeah,
they said, look at where it's coming from, the address, the Amazon address.
Yes.
Because it is different
Could be
Yes.
one
than
letter
the
off.
It's
right?
like, I
Yeah.
forget what the difference is, but it's not their standard Amazon.
so that's something called typo squatting. So for example, it could be Amazon.com, but you're getting it from Amazon with an extra N.com,
Yeah.
Right.
something like that.
We used to get it here where it would be, instead of nychhc.org, you would get nychhh.
Has caught me is when they said, and the name's familiar, like, oh, I'm looking for you. Can you send me, I don't know, your phone number or something like that?
Yeah.
Yeah.
Or give me a call, something like that. So, and then I one time was from my department head, so I responded right away. But they didn't do anything with it. But I guess they validated that my email was correct, and then I started noticing that the email address was totally different. So
Yeah.
yeah, they can be very sophisticated.
It has
and
gotten very
very
sophisticated.
sophisticated. I do have any question? I do have a question. You know, one of the things that we have been hearing a lot more in cybersecurity is the whole concept of cybersecurity capability maturity models. And I know that you referred to NIST, and even though they don't have a capability maturity model, they do have levels
Yes.
that you can kind of say, like, I'm at that level of cybersecurity and all that. Do we know, do we keep track of that and position ourselves on
Yes.
what level of that? Are we considering to look at a cybersecurity capability maturity models to understand where we are compared? And I know that it's different for hospitals, but I don't know if other other systems are following a similar model.
And we actually do that, and we have quite a bit of information. We'd be happy to have an educational session for the board on where we're at with that. And this has actually matured I would say over the last 3-4 years, quite a bit, and we can actually show, our progress over that period of time. But we would be happy to provide a more detailed report on that to the board.
I would love to hear more, but maybe in one of the official IT meetings, you can very briefly explain where we are, what are the maturity models that we are following, where we are in each one of them, what other systems are following, because a lot of the things is the benchmark. I think Dr. Bolton, you may be at fault for this question, because Dr. Bolton shows us every time how we're doing in the MAC chart comparatively to peers and to kind of the industry standard. I think it will be good and cybersecurity is so much in our minds
Right.
right now that I think it would be good to know where we are compared to our peers and the industry standard.
So
Again,
just-
very briefly, but
Right. So Kim, if I could just say a couple of points. So in 2020, we actually conducted an assessment to see where we are compared to other healthcare systems across the board. So that assessment was done in 2020. We can provide that information.
That was external or that was internal?
So it was done through an external party, and they reviewed our entire security programs in essence. And also that ties into the yearly risk assessments that are also conducted from a third party as well, that we then create our own risk management plan to follow our processes and make sure that we are reducing the risk level for health and hospitals. And the assessment, I've actually asked for the assessment to occur again. We're actually in the middle of trying to get that done. So I'm hopeful, I say at the end of the first quarter next year or something like that, I would have that data so I can present that if you would like.
so that may be a good timing. Maybe what we can do, we can have an informational session in which you understand what the process you're going. And then after the results of that assessment, then you present it in the public meeting.
Right.
So that we know what was the result of that review.
Sure.
I think that will. I also have.
Can I ask a follow-up?
Yeah,
to that?
yes, please.
Yeah.
Yes.
Are there like certification of some sort or processes, quality processes that you can follow on that so that it becomes sort of like embedded in the system?
Yes. So basically, the assessments give us a guideline of what the process that we follow. It's basically, the CSF guideline is you identify, which is the assessment. Once you identify, you have a risk management plan. And once you have the risk management plan, that tells you at a high level what you need to go after for a system,
Right.
or pretty much such as ours. So that's what we've been following, I would say, for the last 3 or 4 years.
Right.
And I can say we've gone from more of a reactive organization to a risk-based system, which is a huge improvement in terms of our cybersecurity posture. And that goes to the entire, EITS department and working and collaborating to making sure that happens. But yes, it's not really certifications, but it's just the third party comes in and they give us pretty much a grade. And they say, here's how you're doing in comparison, and here's how you can improve. So that's basically the assessment.
Is that an
we do.
RFP thing or is that something that you can just do internally? Or?
That is part of my security
Okay, so it's
program.
part of-
I
So it would
basically,
require additional
it's,
approval of funding necessarily?
Oh, we did
It
have
does-
funding approved for it
Yes.
from the vendor who actually, and there was actually looking to assess who the appropriate vendor would be and getting appropriate funding to do the outside assessment. So we started that, and I think that was completed, that request in 2019, and then we actually did the survey in 2020. Took the first steps at the first level of mitigation, which we achieved.
Yes.
And then we went back to the second layered that was brought to our attention. We have worked on that. We've actually made extremely positive strides in this area, and now would be the time for us to get a full reassessment of the same landscape that we have. And plus, as Shoma mentioned before, we know this landscape has expanded, like to biomedical devices. It's not just your laptops and computers, but like an IV pump, or something like that. So we've embraced that and have been there to support us in that domain. Probably more than you wanted right now, but we'll be happy to bring you up to date on that area.
But there are different levels. I think 5 or 6 levels in order to achieve the different maturity levels.
right.
I think that the level and the certification, maybe Shoma, is the
That's, yes.
the thing that might be
Right.
confusing there. Yeah.
And another thing, I know that we are in all our institutions, we're going through the benefits re-enrollment, But now I notice, I bet NYU did the same, but Colombia has this identity theft insurance protection as part now of the benefits for all the employees. Do we have something like that? Do we offer a benefit to our employees for identity theft, which provide like protections, insurance, and things
So
of that nature?
I believe that would be more for our chief privacy officer, chief compliance officer, but I work closely with her, so I can say in the event of an incident, a privacy incident, we do provide identity services, either, you know, it kind of depends on the source of where it's happened, but either the third party would provide it, the third party who was at, at fault, it's probably would provide that, or H&H would provide that if it was an H&H privacy situation. But I would defer to the chief
Okay,
compliance
maybe we'll
officer.
go to find, just for curiosity, because we're now having like this insurance part of our benefit. And that is not associated only in Colombia, it's like any identity theft, and
Right.
supposedly they will fight it out for us, supposedly.
Oh,
I don't
see.
know if that will be
Okay.
true,
But
but.
Penny, that's very good, especially if they're using our equipment, and then the risk becomes another situation. I don't want to belabor it, but I think that's something to consider.
That's a very good point, yeah. Maybe if you find out more about it, that would be good. Okay. Any other questions? No? Mr. Bozo, I guess?
Okay, I'm going to transition over to Mike. This is, also in alignment with our goals. We're going to touch on three key areas here. First, we'll start with our care experience.
Great, thank you so much. So this is our MyChart slide. This is our patient portal where our patients can come in, look at their notes, interact with staff, request refills, and many more functionalities, some of which I'll get into today. On the left-hand side of the screen, what you're seeing is our activation rate of MyChart among our primary care patients, and on the right, it's the bigger chart, it's the all-comers. The all-comers chart is the one that you can compare us to nationally against other Epic customers, and we are still firmly in the top 25% in that range. The Epic average for safety net hospitals like us is 48%, and we're at 66. What I think is going to drive our activation rate and our patients' satisfaction with MyChart in the long term is it's a couple things, but it all gets down to functionality and responsiveness to our patients. So one of the features that we put in that we've now expanded across the entire enterprise is something called FastPass. And what that is that if you're you're a patient and you need to have an appointment with your urologist, you can say, and you say, you have an appointment for 6 weeks from now. You can sign up for the wait list, and we automatically, if an appointment comes available 4 weeks from now, send them an email with a scheduling ticket, and they don't have to call anybody. They just click on the link, say, yes, I accept that appointment. They have a new appointment for that date. That's available for a number of our subspecialties at this point, and we're going to continue to expand that across the system.
I want to applaud you because I know how valuable this is, particularly since we used to do the visit to the different hospitals, and the issue of the appointments with the specialist, it was very, very challenging. So having this is really great.
So that one works again with one, we get one.
So the message goes from the message goes from us automatically. You sign up for the wait list. It goes automatically to that person. They have, I believe, it's 24 hours to respond to it, and we can, and then they can take that appointment. There's one. I'm sorry if you can go back to the last slide. There's one other thing on this is Care Companion is another feature that I've spoke to before that we are working on that's now live. And what that is that it's right now it's only for our OBGYN patients, but our OB patients, but we are expanding it. And it's for healthy pregnancies at this point. And what it is, it's an interactive tool. So it can go through, and you see this in a lot of other things. It says, at 6 weeks that the fetus is this size, and just gives some general information. But then it also gives you checklists on, hey, have you gotten your flu vaccine? Have you done these other necessary steps? So it's a interactive tool that's electronic and automated. And then it also gives them the ability to do messaging with their provider. That is something that is only live at one of our hospitals right now, but it is going to be expanded. The OB Council wanted to go live at one hospital. They've been very happy with it thus far. The intention has always been, it was gone live at one site, but it was built across the system. So that's how we do things. And that's another functionality that's being driven here. And what I will mention is you're going to see, I talked about moving away from just focusing on the activation rate to really focusing on patient engagement. And separate from this committee, but the strategic board dashboard, there's a MyChart metric that you're going to start seeing in that venue now, and that's MyChart message handling responsiveness, which is how long it takes us to get back to a patient. And it's actually going to be the percentage that we get back to within 72 hours, which is the exact metric you're going to see. So that's where we're shifting our focus to. It's way more on the usability of the system and how both the patients and us, meaning H&H providers, are using it.
Is it called Mom's Place?
Is it called what?
Mom's Place.
Oh, what is Care Companion called? There's going to be some cutesy name for it. Epic always does.
You have a contest.
I think this one's actually rather dull. I think it's OB Healthy Pregnancy. Yeah, I think that's what this one is.
One question I have with that is, once you have providers gotten the message, hasn't answered in 3 days, what is our backup to make sure that there's either another provider or someone else?
Yeah.
I mean, we'll get the statistics, which is great.
Yeah.
And we'll have some idea of, the turnaround time. But how do we escalate it if there's an issue?
Spent a little bit on message type here, and this is something we struggle with. It goes first to general messages. Will generally go first to a nursing pool, which should get a response, and then they get routed to generally the primary care physician or whoever the appropriate provider is. If that provider does not respond, is exactly what we're working on right now. It's very hard for somebody else, like an administrator, to respond on behalf of the primary care provider. Some things we can do, refill requests for medications that they already have a refill on file and they just need something out there. That probably should never go to the provider in the first place in some instances. So it's, to answer your question, the way I think we're gonna, kind of indirectly, we need to have as few things going to the provider in basket as humanly possible, and then really work with them on being responsive, which is why ACLC is tracking this so tightly, and why it's going to be one of your board metrics.
Yeah, that's the ambulatory care committee.
Sorry, yeah, the ambulatory care leadership.
I don't know if Dr. Allen or you, Jose, that shared article in which it showed that women doctors tend to spend more time responding than
Yeah,
men.
actually,
I think it was you, I believe.
that, but it's a well-known data fact that women spend more time seeing the patient in the first place. So the face-to-face in the treatment room is going to be a little bit longer if the physician's a woman. And then Mitch shared that women spend more time responding to these electronic queries. That's who we are.
Yeah. But I think when I saw that article and now talking that we are going to be showing that as a measurement, I believe that we as an organization have to acknowledge that fact and identify ways in which we reward the people that are doing such a great job, because now this is important to maintain the engagement with our patients and providing the necessary support that they need. And I think we should be thinking more holistically on how to acknowledge and reward that.
So I'd like to first look at our own data because I think we are unique in the public hospital system. We're mission-driven. I don't want to overstep here, but I think we recruit or retract a very different physician type than in the voluntary sector of the private world. So around gender equity, collecting data, I'd be very interested in looking at, I don't know if you can collect this, Mike, response times by gender, race, and ethnicity.
I think that would be interesting, and then maybe do something.
Yeah.
And, sometimes that reward you're talking about doesn't necessarily have to be financial.
Yeah.
Sometimes just acknowledgement. So as
Recognition.
long as we have this data, we have it on two ends. One, to be able to reward people with short turnaround times and high percentage of turnaround of responses. But the other half of it, again, which is the dilemma you're talking about, but which is that those either who have gone beyond that window for turnaround time or are really a problem answering at all potentially where the message can be lost, which could have a very significant medical legal aspect to it as well, that we have to sort of be able to have educational response to those things. So I think both capturing it for the purpose of hopefully being able to intervene and escalate it somewhere so we don't lose these things, but also, and as Penny said, some system of, again, reward. And again, often providers, a pat on the back is a wonderful
Yeah.
reward, and knowing that you're doing a good job is often, that's true of
yeah.
nurses and doctors as well.
The tendency tends to be to do the opposite as human beings and say, okay, if you're really not responding to anything, we'll punish you. So I do like the idea of sending the message, look, we expect you to be on top of your game, responding within 72 hours and so on. Because it sends a message to everyone that this is something that we value.
Just to give you an idea, back in the old DRG days when doctors got responses, you remember those, when doctors got responses about why there are 2 standard deviations out of their colleagues, they panicked and changed behavior because it's like, oh my gosh, someone's looking, and obviously I'm not performing as well as my colleagues. And I think sometimes that in of itself is enough, plus educational pieces as well. But I think we also have to keep in mind some, as I said, mechanism. If someone is a chronic non-responder, we have to address it somehow. And one of the ways is, again, get somebody to respond, because we don't want to have important messages get lost. And I'm sure you have some, warning in advance about the type of messages you should be sending, but people don't always acknowledge that. So, I have chest pain this whole week. Maybe they don't understand that shouldn't be a message, but on the other hand, it could be. And we sure don't want to lose that, that answer.
I think there's a whole enterprise-wide effort on looking at, under the rubric of professionalism, signing notes, responding to messages in my chart, following up on BI-RAD zeros.
Yep. There's 244 different MyChart message types that can flow into a physician's in-basket. The ones both of you just mentioned, we've identified as the top 9 that are automatically floated to the top of your chart or the top of your in-basket and are a different color to attract attention there. So, and there are ways you can respond for somebody else, but it's a hard process. This is a problem that we're going to pay a lot of attention to, and it's multimodal, right?
Thank you. I like the idea of reducing the overhead to the physician, because again, they're working really hard and creating that kind of prioritization list. So I think it's important. And again, going back to what Dr. Calamia said, let's never underestimate the power of peer pressure. Either for reward or for criticism. And I just want to go back to this chart and just to understand. I think thank you for kind of clarify. The one to the right, that is all the activations for all our patients.
Includes ED, inpatient, specialty care, all of that. The one on the left is just patients with a primary care doctor at New York City Health and Hospitals.
Great. And the bold numbers in dark blue bold is the primary, and the 39 is the total. Is that correct?
I'm sorry, say that again?
If you look at Lincoln,
Yeah.
they have 36,000
Yeah.
in bold, like dark blue, and then 39,000, almost 40,000 in light blue.
I see.
Right, so 36,000 out of 39,000.
So 36,000.
Yes.
Oh, so the total number of primary care the patients with primary care is 39,000.
Yes.
Okay, I thought that these were the
Yeah, no.
primary care, and then the other ones were a total. No.
Numerator and denominator, you got it.
Okay, this is great. This brings me to this question. And again, I don't want to say anything about any hospital, but we have Coney Island here. That it is in the lower end in 63%, which still is very good compared to everybody.
Average.
But if we look compared to our average, it's below average. But then if we look for the total population,
Great.
they are kind of high on the top. So what is the difference there? That is a little bit interesting.
It is very interesting. So we've done analysis on this one because it's an outlier. It's very strange that they're not doing great in primary care, but they are doing very well with specialty care and when the patient comes to the emergency department to get activated. And I will be honest with you, I do not have a definitive answer. I have some speculation points that I'm happy to share, but I don't I don't know what's driving that, but it is something we have looked at and looked for what's driving it. There appears to be an age where they have a slightly older population in primary care, but
Oh.
that is the
Unofficial.
that is the unofficial, but is the best estimate. That is the best guess that I have at this point, having looked at that issue.
So I don't understand, Michael, how much of this is, because if you received a COVID vaccination or test, you were enrolled, so how much of this chart on the right reflects COVID activation? And maybe Coney Island had many more patients getting,
This shows in order to be considered active in my chart, you need to have logged in once in the past 12 months. So some of this, so if you
It's a rolling
activated,
12 months
yeah, it's a
also.
rolling 12 months. So if
Right.
you've activated, 2 years ago or 18 months ago, and you came in, you would no longer be counted in front of this. So I'm going to say COVID is certainly still a factor with this, but it is no longer the driving predominant factor.
I mean, East New York has the greatest delta, 88% on the right and 68% on the left. That's a major delta. So whatever, I guess, to answer Finney's question, maybe we can follow up with him if we get more information on the
It's
delta.
funny, just last week, the reason I kind of knew these stats right off, but we looked at this during the MyChart steering committee, and we had the delta lined up. We had another column next to MyChart activation with the delta and conversation about what's happening at each site. And some of the sites are just have very engaged specialty care doctors that are using this. So there's some local variation when you get into smaller numbers with some of our smaller Gotham sites, where a couple of individual providers that are really engaged or less engaged really do drive the variation at those smaller Gotham sites like East New York.
Interesting.
At the larger sites, there's so many that the numerator is large enough.
But I guess in this chart, Coney Island stand out because everybody else, the performance with their primary care is higher than the overall, or not necessarily everywhere, but definitely they meet. And only Coney Island seems to be out of sync. So if it is okay, it will be good that for the next meeting, we have a little bit more explanation of what is happening. I think maybe your theory of different age groups may have something to do, particularly with technology, but it will be good to find out and see how that can be addressed.
Yes, we can
if there
dig
is
in.
anything.
That was the only variable that we looked at that was different between them and others. So I can get more data on that.
Is the way they are enrolled or given the information pretty much standard, or is there a possibility that those that are doing the enrolling are not?
That's a
Yeah.
very
you know,
good question.
as adequate?
There's an automated portion of this, and most of our patients come in through an automated process. If you come see us at New York City Health and Hospitals, we send you a message right after your visit to enroll you in MyChart. We give you an after visit summary that gives you the ability to come in MyChart. We do that for everybody, and that's where the majority of our patients come in. We do have a smaller targeted group. They're called patient portal liaisons that can help patients sign up, and that could be where some of the variations.
Or even not beyond those people that are sort of specializing in that, there may be different degrees of how aggressive people are to make the patient aware that they're going to be getting an automated message, this is what it does, so on. So maybe that's an area to look at, because otherwise but again, it could be age and so on. Some of them may be nursing home people. I don't know. There may be other variables, but I'd want to look at that particularly.
I'd also like to know what Lincoln is doing. They're so far out ahead of the rest of the pack. Why are they so successful?
So, well, there's a number of things here, but Chris Roker, their CEO, is a member of our MyChart steering committee and really champions this locally. Their entire team we work with regularly on how to make this better. They were very happy to adopt FastPass and a number of other features, and they champion it locally. So I think
Leadership. It always
I think
boils down to leadership.
It goes back to that. Yeah.
By the way, be careful that you don't have a Disney issue with copywriting on FastPass.
Oh yeah, that is.
Just watch out.
terminology, not H&H.
Okay, fair enough.
So I know we only have about 9 minutes,
Yeah.
but I do want to, Mike, if we could just skip ahead to a couple of the Epic areas, one more or two more,
Can we
please.
do voice?
No, I want to do the Center X. I
Okay,
think is
yeah.
a very important implementation. That's good. You're there, yeah. If we could do that, and then the, maybe the wisdom, which we just finished, those would be really key pieces of, if the chairman's good with
Yeah,
that.
it's okay.
Yeah, all right, perfect. So let me tell you about Center X. So right now, when I write a prescription for my patient, and it depends on which PBM, pharmacy benefit manager they have, which no one knows what pharmacy benefit manager, so this has to be done in an automated fashion. If I write them for a medication, and let's say I write them for a statin, and their insurance doesn't cover that medication, they're gonna have a high copay. But if they do cover what is medically an analogous, basically the same medication at a much lower out-of-pocket cost to my patient, I don't know that in a very good manner right now. So it goes to the prescription, it goes to the pharmacy, maybe the patient goes, they decide, well, I don't have $60 to do this right now. But I can know in advance what their copay is going to be with the completion of this project, which this part here that I'm just discussing, which is real-time prescription benefit, will be in by the end of December. What that will be able to do is I can say, oh, I won't prescribe you statin X, I will prescribe you statin Y, and then your copay is only going to be $5. So this gets down to really equity
Yeah.
and driving our patients to get the medications that they need in a way that is conducive for them. The second piece of this is the electronic prior authorizations. Some medications are not covered by insurance unless you get an electronic prior authorization. And today that process is painful. It involves a fax. It frequently involves a phone call to the insurer on the part of the provider. So what we are doing is, like, let's just say you need one of these. You get told in advance you need one of these. It doesn't get denied and sent back to you. And then it gives you the ability right within, from the provider's perspective, right within Epic to fill out an electronic prior authorization. Some of them get approved right away, and otherwise it is electronic communication. So gone are the fax, gone are the phone calls for the, over 90% of these. So this is a real benefit to our patients. They're getting the meds they need. This is a huge benefit to our providers because that is not value-added time that they've been doing. When you talk to providers about things they do not like in their workday, specifically in ambulatory, electronic prior authorizations is high on their list of complaints. So this is us trying to address the joy in work and the social needs of our patients.
It's a godsend.
This is good.
To put it bluntly.
To be transparent, we do some of this today already, but not enough of our pharmacy benefit managers right now. And that's what CenterX does, is it plugs a lot of our holes to allow us to do this for the vast majority of our patients.
I think Ms. Lowe has
Yeah,
it.
there, I had a clinical experience myself with the eye drops, glaucoma
Yeah.
eye drops. And it went from $40 from Aesop and Combigan to $325
Wow.
at the beginning of the year.
Yep.
When I went back to see the doctor who is just monitoring me at the diagnostic center, which is wonderful, he's given me only the Combigan, and he is giving it in the two components, the original components, which is going to cost me $13.
Yep. That's exactly the kind of thing this does.
That's awesome.
And we
That's the research
and
that
we would've-
maybe some students could do, and a
And we
little
would have wanted
project.
to know that in advance so that didn't happen to you and other patients. And that's what the real-time prescription benefit's going to head off.
I think
Incredible.
Your point too, the time loss, because first you get the prescription, then you get the bill that it's gonna be, then you go back to the doctor and say, what is this all about?
Yeah.
I paid it.
And then, right, or don't, and you end up paying it. So it saves time all across the board, so this is
Yeah.
huge.
Yes, no, this is good.
Big.
Very, very
But also ensure that the patients use the medicine, because when you get those sticker price, what you're going to do? Stop taking the medicine. Is that or eating?
That is
You
the
know,
epidemic.
in some cases.
Exactly.
I see this in the emergency department not infrequently, where your patients
So I
have.
think we'll close today on a great story of wisdom.
All right.
If Mike, if that's okay.
All right.
I just have a question
Oh,
very
sure.
quickly. Why is Elmhurst not implementing pumps? Because
Yeah.
they already have it, or
Yep, they bought a separate pump recently that the end of life won't be for a number of years. So the plan will be eventually for Elmhurst to move on to the
Right.
new pump, but they're not right now because they have relatively new pumps. Okay.
Okay.
All right, so Wisdom, which is the Epic
Good
dental
question, though.
module, is now implemented and live throughout all of New York City Health and Hospitals. This has brought all of dental and medical into the same world, which is where it should be. Oral health is part of your health. So it's gonna give your primary care doctor better insight onto if you need to be seen by your dentist. Do you need your fluoride treatment for a pediatric patient? And then it's going to make the dentist's lives easier. And this also goes for oral surgeons because they were living in two worlds. They had to be in the other old software part of the time and then Epic for part of the time. So from a patient care perspective, it brings everything into one spot, which is a big win. And from a provider standpoint, it stops this having to switch between systems. So and I got to tell you, the dental council have been fantastic partners in this implementation, and we're very happy to have finished
Yeah, just this last week.
a very major project.
So two questions for you, Michael. The imaging, the dental imaging is in Willow, and the billing is in Willow.
Wisdom.
Wisdom, sorry.
All right. The images, similar to in medical images, the images actually go to a separate issue. They go to something called DEXIS, which is a PACS system for dental images. That actually hasn't changed. We use the same vendor on that. The change is we now have an enterprise version of DEXIS, which means that if the patient shows up at Harlem and they go to Lincoln, the dental images can be seen across, and that was not the truth a year ago.
So they go into a PAC system,
A dental PACS, yep.
dental PACs, but it's accessed universally throughout the
Enterprise.
enterprise.
Yeah.
Billing is better with Wisdom.
So it's early. So we went live early. It's early on this. I can't yet say it's better. You frequently, when you go live with new Epic functionality, you will not infrequently, I'm not saying nationally, see like a 6-month decline for about 6 months, and then you increase. We never had that in New York City Health and Hospitals. We always just went right up, and we went way above where we had been with all of our Epic implementations. We're not seeing that yet, but we're not actually far enough out that I can give you concrete evidence on it yet,
Right.
or concrete data.
You're
on it yet.
optimistic.
Yeah, I think in the medium term, I'm very optimistic.
Great, thank you.
Thank you.
Very nice.
And I think that will, bring us to a close. We can certainly bring an update on the other items. And the very last slide is just this rediscovery that we've been doing with our Epic Rovers, which is a handheld device, and an iPhone, which we've recently upgraded, and we're deploying those across our system. And many facilities had them. They're role-based. It could be used by someone from transport or a nurse or radiology tech. And it really does allow a great more flexibility. If you're a nurse, you can actually do med administration on it, do documentation on that, and then it translates over interfaces with Epic, the electronic health record. And just like anything, like your own new iPhone, something new brings new. You learn so much functionality, and then it's important to have an ongoing, and we're calling it rediscovery, so that you learn more functionality of a tool that you already have.
Who's allowed to use it and who's not allowed to use it?
Mike can do it, but we have, as I mentioned, they are role-based though.
Yeah, Rovers are role-based, so it's nursing. It's nursing and other nursing functionality. So it's nursing, LPNs are the groups using it. I think PCAs also, patient care associates, will also use it, but what they'll have access to is different than what a nurse will have access to.
And also transport uses them from we're moving to know when a patient needs to be moved from one place to the other. And the reason the role base is important is that they go into the same device. We could all have the same device, but based on my role is what component comes up on the device.
So if I'm in the ED and I'm inpatient and I want to transport a patient from the ED to the CAT scan, does that get documented someplace?
Yes.
Yes.
There's a patient transport that both doctors and nurses within Epic that have access to request transport,
Right.
and that goes to the device that the transport team is holding.
Great, thank you.
Thank you. Any?
No, I just want to close and thank you for the opportunity for us to share our initiatives with the Board of Directors Committee.
Thank you, Kim. We really appreciate it. Again, thank you, Dr. Bolton. Thank you for your presentation. I just want to check with the committee members. Are there any questions, any comments?
This is a very interesting presentation and very useful, so just want to thank you.
Kudos.
Indeed. Particularly for IT, sometimes tends to be a little bit in the boring side, So it's a little bit engaging. So thank you for making it. Any old business? Any new business? If there are no further discussion, all in favor of adjourning this meeting?
Yes.
Yes? Okay, thank you, everyone.
Thank you.